Whilst incorporating the clinical reasoning cycle, myself, Emily Dixon, Amy Ashman, Amy Johnston, Ashley Foster and Emily Leenan will present our proposal for this assignment. The issue being addressed in this proposal is third-degree tears in birthing women. The National Safety and Quality Health Service Standards, developed by the Australian Commission on Safety and Quality in Healthcare, primarily aims to protect the public from harm and improve health service quality. Of the 8 standards, the most relevant standard to this case is the Comprehensive Care Standard. The intention of this standard is to ensure the provision of coordinated, holistic and clinically appropriate delivery of care that prevents and manages the risks of harm that may be present to a patient. In Australia, most women who have a normal vaginal birth do not experience perineal trauma. However, 3% endure a 3rd or 4th degree tear. With the underlying theme of the 5th standard, providing collaborative, communicative and continuous care while assessing and managing the patient's clinical risk, that being 3rd degree tears, is the issue that this proposal will be addressing. For this project to be successful, a range of professions must be involved, those being midwifery staff, the obstetric team, and the labouring women. With all of the relevant information that we have gathered while formulating this project, we have set our aim to be to reduce 3rd degree tears with warm compresses in all vaginal births by 30% compared to vaginal births employing a hands-off technique at Monash Health between January 1st, 2020 and December 31st, 2020.
There are several factors that can influence tears, which are expressed in the following affinity diagram. In the study conducted by Gurul-Organci et al., the occurrence of tears were different between age groups, various ethnicities, if the woman had had an episiotomy, and the mode of delivery. Gurul-Organci et al. Expressed that the training of staff impacted on the awareness, prevention, and management of perineal trauma. During a vaginal birth, perineal tears can spontaneously occur, causing harm to the woman. Based on the depth of perineal injury, they can be classified into 4 degrees. For the purpose of this study, we will explore 3rd degree perineal tears. According to the Royal College of Obstetricians and Gynecologists, a 3rd degree tear is a laceration involving the anal sphincter muscles. Specifically, 3rd degree tears are further classified into 3A, which is less than 50%, or 3B, which is more than 50% of the external anal sphincter, or 3C if the internal anal sphincter is involved as well. In Australia, most women who have had a normal vaginal birth do not experience perineal trauma. However, 3% endure a 3rd or 4th degree tear. Problems may arise soon after and in the future following a 3rd degree perineal tear and may lead to tears in subsequent vaginal births. Fragario et al. Stated that trauma of the anal sphincter can lead to anal incontinence, chronic pain occurring in the perineum and surrounding area, pain during sexual intercourse, and poor mental health. Repair of the perineum and anal sphincter may require surgical intervention, and problems such as fistulas or abscesses can also require further surgery.
So to highlight our goal is to reduce 3rd degree tears with warm compresses in all vaginal births by 30% compared to vaginal births employing a hands-off technique at Monash Health between January 1st, 2020 and December 31st, 2020. In order to achieve this, the action we wish to implement is the use of warm perineal compressors during 2nd stage of labour. The use of warm compression is said to enhance vasodilation and blood supply, relax perineal and surrounding muscles, alter the pain response, and improve stretchability of the tissues.
To reduce the outcome of 3rd degree tears during all birthing women, we wish to implement a change in practice. We plan to carry out our action through all Monash Health sites. The participants will include 600 women who volunteer to have their state of their perineum recorded. The control group will include 300 women who will experience a hands-off technique with no interventions, while the experimental group of 300 women will experience warm compresses applied to their perineum during 2nd stage of labour. These conditions will occur for all women experiencing a vaginal birth regardless of the mode of delivery. Women will be offered to take place in this study whilst attending their antenatal appointments. If a woman chooses to participate in the study, they will be asked to complete a consent form. After this, they will be randomly allocated to either the control or intervention group. The use of a random allocation will ensure there is no bias when people are placed in a group. For example, if all women of Southeast Asian descent were in one group, the results may be influenced by their ethnicity rather than the technique used. This information will be documented in a woman's BOSS in order for the primary accoucheur to determine if they are applying warm compresses or the hands-off technique during the second stage of labour.
The first step in conducting this study is to provide education to the midwives and other staff. In-services will be held to inform staff of the implementation that we plan to carry out through Monash Health. The in-services will also be used as an education session for midwives to learn how to correctly apply warm compresses, as well as the correct procedure for a hands-off technique. For example, midwives must be aware that if they are applying a hands-off technique, once any sort of pressure has been applied to the perineum, it is not considered a hands-off approach. Once women enter the birthing environment for a vaginal delivery, the midwife will maintain normal procedural care as per protocol until identified to be in second stage of labour. The midwives of women in the control group will remain hands-off and only observe for the mechanisms of birth. If the baby's well-being becomes compromised, the midwife can intervene through assisting with the birth of the baby without touching the perineum. As a practicing midwife of the experimental group, they will prepare pads soaked in warm water and apply them to the woman's perineum, ensuring they can still observe the baby's entire head. In order to evaluate the outcomes of this proposal, after the baby is born, the midwife will examine if any tears are present and if so, the degree of tear. They will then record the findings in a confidential document that midwives and other people conducting the study have access to. At the conclusion of this study, the results will determine if the intervention of warm compresses on the perineum impact the risk of third-degree tears.
Staff will conduct a survey halfway through the experiment in July to assess their level of confidence and their perspective as to how they are performing their technique. The midway survey will be completed to ensure midwives and obstetricians are comfortable in their practice and therefore performing safe practice. This survey will also evaluate the accuracy of the study and ensure staff are performing the correct procedure according to the women's allocations for the experiment. This survey will then be completed at the end of the trial to display how satisfied the staff were completing their technique. At the end of the experiment, the midwives will also have the opportunity to add feedback on how they would implement this practice in the future to improve outcomes and patient safety.
So lastly, after the study has been completed, we will implement several changes to continue to reduce third-degree tears in future practice. Based off the study results, healthcare policies and procedures at Monash Health sites should be changed to include the use of the technique that results in less perineal harm. We will also encourage maternity teams to continue to adequately perform perineum and rectal examinations and document the findings in BOSS. This will continue to allow perineal tears to be identified so that solutions to prevent tearing can be put in place. In addition, we will encourage the implementation of yearly in-services, outlining the latest evidence-based practice on prevention of tears. This may include reiterating the technique on how to adequately apply warm compresses to the perineum so that midwifery staff are effectively trying to reduce perineal tears. Lastly, it is important that any new staff are educated regarding the outcomes of the study and they too use effective preventative measures to reduce perineal tearing.